But welcome to Uromigos Live 2024, T-cell directed therapy in prostate cancer. I have an excellent prostate cancer who happens to be sitting in the exact order that their pictures are. That's a small miracle. So I will turn it over and have you introduce yourselves in sequence. Michael, why don't you start?
Sure. I'm Michael Morris. I'm the prostate cancer section head at MSK.
Hi, I'm Tanya Dorff. I'm the division chief for genitourinary cancers at City of Hope near Los Angeles.
And I'm Karen Autio. I'm a GU medical oncologist at Memorial Sloan Kettering.
Appreciate, again, you all joining us. So let's dive into T-cell therapy. So this is a slide that I adapted. Niraj Agarwal, who couldn't be here this year, has been here in the past, gave a talk on this broadly at ESMO, and I borrowed some of his slides and rearranged this sort of as an intro slide to talk about T-cell therapy and T-cell engagers, these TCEs in general. And if you look sort of at the top right, I think, to me, that's the definition. They bypass some of the normal mechanisms for T-cell engagement and stimulation, and in essence, bring T-cells to the tumor, right? So you see the CD3 positive T-cell, you see a number of drugs that we'll talk about, some of them, not all of them today, and then on the prostate cancer cell, you see the tumor antigens. We'll talk about sort of bottom left upwards, PSMA, which we're familiar with, and we'll talk about in radioligands, of course, STEAP1, and then DLL3. And the various drugs that target them. And these are obviously just a small subset, but the ones that have some clinical data. So again, it's really bringing T cells to the tumor is how I think of T cell engagers. And on the left are just the definition of some of those antigens that you're familiar with. All right, before we talk about the drugs themselves and the trials and the data, and by the way, Karen helped me make all these slides, thank you. Actually, she made all the slides, so thank you for that. When I say helped me, I mean she made them. Cytokine release syndrome is a big issue, right? So we're talking about a potentially toxic therapy. We'll get into it in a population that's generally older and comorbid, perhaps in some of our other solid tumors. And cytokine release syndrome, or CRS, is a big deal. So these are the boxes, sort of this so-called Lee criteria. You see the reference down there. Karen, maybe if you could sort of take us through what is CRS, what are the cytokines mediating it, how did this grading get decided? I think the bold sort of points out that grade 2 is a big deal. Like normally we don't think of it as a big deal, right. But if you're on a vasopressor, that's a big deal.
Yeah, definitely. So CRS is sort of this overwhelming inflammatory response that's characterized by pro-inflammatory cytokines like IL-6 and interferon gamma. I usually describe it as in its more severe form, it can look like sepsis. So patients can get hypotensive and tachycardic. They have fevers and chills. For those who can see the slide, there's certainly a different number of organ systems that can be affected. And the grading system that we typically use is the Lee criteria, although there are other grading systems. And I'll just walk through a little bit about how we grade CRS, because I think it's important when we look at it in the context of the trial results. So grade 1 CRS is fever, maybe some chills. It's mostly just sort of symptom management. When you get into grade 2 CRS, things are more tricky, and patients oftentimes have hemodynamic instability, so they may have low blood pressure that responds to IV fluids, or they may need a low dose of a vasopressor, tachycardia, grade 3 transaminitis, which is common, at least with our PSMA-directed bispecific T-cell engagers, can also qualify somebody for a grade 2 CRS. When you get into grade 3 CRS, if it's for hemodynamic instability, those patients are certainly in the ICU.
And it sounds like, just to go back to grade 2, it sounds like it's a broad range, right? Because you say it's generally inpatient, so not exclusively, all the way up to ICU.
Correct.
So
Correct. So grade 2 runs sort of the gamut, and grade 2 can also be, you're just in grade 2 because your liver enzymes are elevated, which is very different, obviously, than, you need to be on a low-dose vasopressor in the ICU. So that all comprises the spectrum of grade 2 CRS.
And then, I'm sorry, you were
and
talking
then
about grade 3.
Grade 4 and 5, fortunately, we don't really see too much of that, but that's certainly, patients in the ICU and are dying of cytokine release syndrome. I'm not sure if we'll get into later, so the mitigation strategies for CRS, we probably will, but I would say just generally speaking, we use tocilizumab, IL-6 agonist to mitigate grade 2 CRS, and oftentimes in grade 1 CRS for patients that have comorbidities where we're concerned about the progression of the cytokine release syndrome.
And you treat with steroids at all or no?
And steroids as well, yeah. Steroids typically in grade 2, and there is concern that too much steroid could potentially decrease the efficacy of these drugs. So we do use steroid pre-medications, but how often to give them in grade 1, grade 2, I think is ongoing discussions.
generally the same approach as IO-mediated toxicity, but maybe earlier use of like tocilizumab or
Correct.
an IL-6 antibody. Is that a fair
That's
statement?
fair.
Tanya, you have a ton of experience as well. Anything to add? I mean, it seems like this is a big deal, right? Is that an accurate statement?
Yeah, I mean, it's been one of the challenges with rolling out bispecific T-cell engagers is the high rate of CRS, especially in the first few doses. It does tend to diminish over time. But during those first few doses, trying to send a patient home knowing that they're going to have fever and chills, and you prepare them the best you can, but it can be a lot for them to try to get through it on their own, and a lot of times they sort of do feel more comfortable in the hospital where a nurse can come and help them through the side effects. And then also just thinking about the community, if you have a general hospital, do they have tocilizumab? If a patient shows up having received the bispecific and having CRS, are they equipped?
Two questions. This is generally given, the drug administration is inpatient, or not necessarily?
Usually at least the first dose, although we're trying to minimize the inpatient requirement.
And then they stay for a day, a week?
A day or two
Okay.
at most these days, yeah.
But you have a low threshold to bring them back in the hospital for the reasons you mentioned.
You have to have a really good, reliable system where they can call in and get help and know that they'll get the TOCI if they need it.
And do most emergency room docs, they know what, Pembro or Nivo is, and if they show up, Karen's shaking her head, like, if they say, oh, I got, AMG, whatever, like.
They're not going to know. They're going to treat them for sepsis. They're going to give them,
Yeah.
fluids and vasopressors, but I don't think they're going to know to give TOCI or
They probably don't
or
have
steroids,
it.
at least at this point. I mean, but that's why it's being done in large academic centers while we sort of figure this out and figure out the best way to transition these patients to outpatient.
Got it.
I just want to echo something that Tanya said because I think it's really important. The CRS it's the first few doses, and we tend to do step-up dosing, right? And so they might still have CRS at their target dose, but this isn't something where somebody's on therapy for 3 months and then all of a sudden they're getting hypotensive at home.
Like this
it's
happens,
very
right?
predictable in terms of when the CRS onset is,
Which is right away, basically.
which is within the
Within
first
Within
12
a few
hours.
hours, yeah.
Oh, within hours.
And I think before scaring the entire field away, it's worth remembering that, first of all, even with the early days of checkpoint inhibitors, everyone was scared of how to administer them and how to educate the community in managing side effects. And remember that tarlatamab is FDA approved for the use for small cell lung cancer. And we aren't bursting at the seams within patients with a whole bunch of small cell lung cancer patients, and it requires just a day's worth of observation, not necessarily admission. So there is experience. This class of drug is FDA approved. People are managing. So before we say, oh, this is scary,
Always the
horrible,
voice of reason.
We'll learn how to do this.
Yeah.
Patients are getting these therapies as part of routine cancer care now, and
If it's active, we'll figure out the tox management,
exactly.
right? True for any cancer drug. Yeah, I was going to ask you, but I think I know your answer. Like, how scary is this to you? But I think I know your answer. Like,
well,
could you give-
I would call Karen, but I think that if you think of the number of generations of both therapeutics and diagnostics that many of us who have been in the field for a while have had to learn how to do new things. This is just
and we're giving
doing
CAR
new
T cells
things.
and other disease and other scarier
Yeah.
things.
Yeah.
Obviously, the substrate here, the prostate cancer patients are a little different than an ALL patient or something, right? Which is
Absolutely,
relevant, but-
absolutely. But the prostate patients aren't necessarily any sicker than the small cell lung cancer patients, right?
Fair.
So I do think that we can learn how to manage this. We'll acquire the skills to do it. And what seems very intimidating right now will be old hat when these drugs hit. They are active. It's the first immunotherapy that we have that's active therapy. So I wouldn't overemphasize the CRS to scare everyone away because, one of these drugs...
Karen suggested I put it as a second slide. Yeah, sure. Tony?
So which one
Your microphone.
can be done most likely outpatient?
Give it to him. Tony, use the mic just because we're recording. Thank you.
Which one can be done outpatient, inpatient, etc.? I mean, this is not just CAR T, but in the future, the CAR NK can account seems to have way less CRS. Maybe some of them need deconditioning. That's where the problem has cyclophosphamide. Others do not need deconditioning. There's always renal cell that patient really progress very fast. So I think this would be important not to treat them all the same. We have a lot of push dynamics-wise at the hospital to move everything outpatient. Which one do you think at first that can be moved mostly outpatient?
Anybody? Tanya?
Well, we'll look at the data, right, for the different agents, or at least some of them. And the AMG 509, the xaluritamig, has lower rates and lower severity of CRS. And as Karen mentioned, it's very predictable. And so I think these can move outpatient. I didn't mean to sound like overly serious about it. It's just going to take some education of both the patients and the community partners. But the first dose or two, some observation, and just having a phone number you can call, I think, and then the rest can definitely be outpatient.
Part of it is, part,
Yeah. Thanks, Dan.
it's not just a drug issue either. It's understanding the patient characteristics that lend themselves to CRS. And also, if you are going to monitor those patients at home, what are the cardinal signs and symptoms that would bring a patient back so that you know, like, oh, this is not good. And, you know, the thoracic world is figuring this out. There's a thoracic oncologist named Bobby Daly at MSK, who has a grant from NCI to study tarlatamab as an outpatient with visiting nurses and EMS visiting. And to get the back and forth patient characteristics, the signs and symptoms that would be triggers for bringing a patient back, and drug selection, all of those will answer Tony's question is, how do we get most efficiently into the outpatient setting?
How do we do it safely? Okay. One more, and then we got to move on from CRS because we're bringing the
Baseline clinical characteristic, you know, gender, whatever, or genomic characteristic.
In prostate, we don't have the gender issue, Tony.
No, I'm thinking all GU. Who will have CRS versus others? Like, are patients with autoimmune disease more likely to have CRS? Do you know anything about that?
I don't think we have good predictive biomarkers, honestly, at this point.
Some people think disease burden might, because there's so much engagement happening all at once.
But you,
I think it's drug
But not
specific,
really.
and I think we could always move on, and I think there's a
think we
slide that
should move
talks
on.
about
I
the
think
CRS
was-
rates with different drugs.
I think no is the short answer to predictive factors.